Hello, my name is Dr. Marc Lerner. I will be discussing developmental diagnoses and an approach that doctors can take in working with families when developmental concerns are a possibility. I am a clinical professor of pediatrics at the University of California, Irvine. I'd like to begin by defining mental, behavioral, and neurodevelopmental concerns. These are typically syndromes characterized by clinical disturbance in the areas of thinking, emotional regulation, or behavior. The disturbance typically reflects a dysfunction in underlying processes of development or behavior. These may be psychological or biological in nature. And the disturbances are typically associated with impairment in personal, family, social, or educational domains. Clinicians should be addressing two specific barriers when considering a developmental diagnosis. The first is the boundary between mental, behavioral, and neurodevelopmental disorders and other diseases or disorders in the ICD-11. The second is the boundary between the disorder and normal behavior. Is this a disorder or a normal variant? In the United States, developmental screening is important. And this slide shows a resource from the Center for Disease Control, which helps parents to understand the expectations for a child's development and lists some of the typical functions which should be identified and mastered by 3 of 4 children at the particular age of the scale. The developmental screening resource on the CDC website begins at 2 months and continues through 5 years. The American Academy of Pediatrics utilizes a common factors review. And pediatricians are encouraged to be optimistic for improvement in a child's needs, to listen empathetically to their concerns, to understand and use appropriate language and not medical lingo when communicating about developmental issues, and to ask permission to explore issues which are sensitive for many families and may involve stigma. This then leads the pediatrician to establish a plan with 1 or more steps for a family to try and work on the concern that has been identified. Does early child development support work? I show you this study, which was done at the beginning of this century, in which early child interventions, both in nutrition and in education and parenting, led to an improvement in child development of approximately 1/4 of a standard deviation on the raven-colored progressive matrices. So this was done in a poor province in Vietnam and showed a significant improvement when early intervention was provided to over 300 children. When we assess development, we also are addressing family functioning and the supports available to support a child within their community. We know that child's emotional and behavioral health depends on having a healthy family environment. And thus we are interested in parental, emotional, and behavioral wellness, and the possibility of trauma, which may have impacted both the parents and the children. We strongly promote the use of healthy family routines, including routines for sleep and for feeding at home. This slide shows a child screening tool often used in the United States. It's called the PEARLS, or the Pediatric Adverse Child Experience and Relevant Life Events Screener. The Pearl is available in multiple languages and can be completed by children, adolescents, and parents to reflect stresses which may have occurred or experiences which may contribute to a risk for neurodevelopmental or behavioral difficulty. What are some of the benefits of developmental assessment? When we do an assessment in a timely fashion, we can have an opportunity for early diagnosis. And early diagnosis allows us to be able to counsel families. For example, genetic counseling may be offered to families when there is a condition which may be passed to multiple family members, such as Fragile X syndrome. We can also provide caregivers with reliable information early before a problem becomes obvious. And this can give them more time to adjust to their child's emerging difficulty and to make management plans for the child, for the child's education, and for their family. Caregivers are often reassured and relieved of their anxiety if an assessment is within the normal range. Multiple assessments can be compared to allow an understanding of an individual's developmental trajectory, helping us to understand if a child may be catching up to their peers. The findings of a child developmental assessment may allow resources to be brought in to support children and their families. Typically, child development and behavioral evaluations are conducted either by medical specialists or psychologists. The medical specialists who are involved include pediatric neurologists, developmental and behavioral pediatricians, child psychiatrists, neurodevelopmental pediatricians, or pediatric physiatrists. The medical evaluation of a child who has a positive developmental assessment is important, and it is the responsibility of the physician. We either do or make referral for hearing evaluation and vision screening, and children who do not cooperate in their assessments need to be seen by professionals such as audiologists and pediatric ophthalmologists so that their vision and hearing status is absolutely confirmed. We can review the newborn metabolic screen, review growth parameters, and pay particular attention to the growth in the head size. We're able to update family, social, and environmental histories, and this may help identify risk factors for developmental delay and then allow for specific evaluations as necessary. Following slide shows some of the considerations which may come up in addressing a child with a developmental delay. A review of antenatal, neonatal, and postnatal risk factors may lead to a decision to do neuroimaging. This may then allow for a specific etiology to be identified, or alternatively, genetic testing can be done, keying in on dysmorphic features, congenital anomalies, or other features suggesting a genetic basis for the problems. Then decisions can be made about ordering tests such as chromosomal microarray and even more substantial tests such as the whole exome sequencing. The physician coordinates the evaluation for coexisting conditions and may be ordering tests to evaluate a child for epilepsy, for gastrointestinal concerns, or sleep disorders. This slide reviews a study of nearly 100 children who had global developmental delay, most of whom had mild or moderate to delays. An etiological diagnosis was determined in 45%. And 4 diagnoses accounted for 3/4 of the established diagnoses. These included cerebral dysgenesis, hypoxic ischemic encephalopathy, toxin exposure, and chromosomal abnormalities. In this study, the presence of coexisting autistic traits was associated with a significantly decreased chance of finding the underlying diagnostic condition. So coexisting medical concerns for the child with developmental delay can include epilepsy, motor disabilities, feeding disorders, constipation, reflux or other GI concerns, drooling, malnutrition, oral health problems, or vision and hearing impairments. In the United States, we often make referral to ancillary professionals as part of our diagnostic process. This slide shows how a child with speech delay was assessed using a hearing test, a cognitive measure, autism screeners, and then a variety of speech and language assessments done by the speech pathologist, leading to the diagnosis of a specific language disorder. Typically, outcome assessments are two at the end of a developmental assessment. Either a disorder is identified or a disorder is not identified. When the disorder is identified, the child should be followed within the pediatric home as a child with special healthcare needs, and this often leads to more frequent medical visits. When the problem is not identified, close follow-up, including developmental surveillance and age-appropriate screening, is then conducted. Early intervention is best for children who have a positive finding on a developmental assessment. We know that environments that do not promote a child's development have a negative impact on a range of social, economic, and learning outcomes over the child's life. And then we know that children develop steadily. And if they're on a deviant path, the course becomes more difficult to change as they become older. Thus, early interventions improve a child's outcome more than later remediation. Early intervention seems to be even more important for children with developmental disabilities than for their normally developing peers. There are a number of reviews that show that improving child development in relatively economically deprived countries is cost effective. In the United States, there are a variety of resources to support children and families with developmental issues. This includes medical referrals, which may be done to speech pathologists or other intervention specialists, such as occupational and physical therapists. Medical specialists can direct families to contact early intervention programs in their community, region, or state. And when children in the United States reach the age of 3, the family is directed to the local public school system for an evaluation to determine if the child is eligible for special education services. There have been studies which have attempted to provide early intervention inside of the medical home with the pediatrician and their staff. These have addressed general development, language, and in behavior. And while there are some positive findings, the effect sizes were very small. This slide shows a typical diagnostic evaluation for a child with intellectual disability. Most of the evaluation centers on the history and examination. Children with dysmorphic features or other characteristics to suggest a particular syndrome undergo confirmatory testing. We know that intellectual disability may be a clinical feature of some inborn errors of metabolism, so we probe for other manifestations such as episodic decompensation, seizures, developmental regression, failure to thrive, or an abnormal finding on the neurological examination or general examination. If no specific order is clinically suspected, then children with intellectual disability are recommended to have genetic testing starting with a chromosome microarray analysis. This is in line with the recommendations from the Canadian College of Medical Genetics, who recommends chromosome microarray and Fragile X testing as first-tier tests when there are patients with global developmental delays, intellectual disability, or autism. Metabolic investigations are to be done when there are secondary clinical features suggesting a metabolic disease. And exome sequencing or comprehensive gene panels are recommended only as second-tier tests. When a child has a neurodevelopmental disorder, outside of the global delays, ID, or autism, genetic testing is not recommended. So, for example, for a child who has receptive language and expressive language disorder, they would alone they would not be recommended for testing genetically unless there are additional features suggesting a syndrome. Neuroimaging and preferably MRI may be considered, especially when there are concerning features such as seizures, progressive or degenerative neurological symptoms, or abnormal findings on physical examination. The literature was reviewed to identify the rate of abnormalities seen on MRI in children with clinically diagnosed intellectual disability or global delay, and whose other examination features was normal. This particular study identified over nearly 2,300 children, and they found that there were MRI abnormalities in 38%. The abnormalities on the MRI led to an etiological diagnosis for the child's delay in 8% of the cases. Diagnostic evaluation tools for autism spectrum disorder include the ADI revised, the Autism Diagnostic Observation Scale, or schedule, or the Childhood Autism Rating Scale. There are other measures used outside of the United States that are also listed on this slide. There are a series of diagnostic classifications of developmental disorders, and most physicians are familiar with either the ICD-10 or 11 or the DSM-5. In young children, there's also the diagnostic classification of mental health and developmental disorders of infancy and early childhood, or DC 0 to 3. This slide shows you some of the kinds of Axis 1 primary diagnoses of the DC 0 to 3, such as adjustment disorders or anxiety disorders of infancy and early childhood. There's an Axis 2, which addresses issues of family functioning, such as anxious or tense family parents or abusive homes. The clinical descriptions and diagnostic requirements are on the basis for the ICD-11, the WHO-developed document which helps to diagnose mental health, behavioral, and neurodevelopmental disorders. The ICD-11 is very similar to the DSM-5, and reliability and clinical utility have been confirmed through comprehensive evaluations around the globe. Components of the ICD-11 offer the essential features of the condition, additional clinical features, information on the boundaries with normality or threshold that help to separate significant finding from a developmental variation, clinical course, developmental presentation, and boundaries with other disorders or conditions, which contributes to the differential diagnosis. So the next few slides show you some of the ICD-11 criteria for neurodevelopmental disorders, beginning with disorders of intellectual development. Disorders of speech and language. And autistic spectrum disorder. The professionals at the Kennedy Krieger Center in Maryland in the United States have provided this 5-phase model to support physicians as they address communication with families of children when a developmental problem has been identified as a developmental disorder. They recommend that the physician who is informing the family should be attentive to the preparation of an appropriate space for the conversation where they will not be interrupted, and to be specific about the goals of the communication they're about to have with the family. And they should be aware of where they're trying to get the family to in regards to their understanding and the development of a plan. Thus, we need to ask parents what they know already, how much they want to know about a child's condition, and then to provide education and to reevaluate your agenda in sharing a developmental diagnosis based on what you're hearing from the family during the course of the conference. Information reception should be monitored in case there are miscommunications, disagreements, or misunderstandings. And then it's appropriate to identify and acknowledge the parent's response to the intervention, to the information provided. While the interview then can be closed, it's important to realize that this is really something which has to occur over a series of visits as parents come to understand more and more of the details of their child's challenges, of the supports for their children, and are able to communicate about the rate of progress that they see in their children over time. So that concludes our discussion of developmental diagnoses. Thank you for participating.